We're out here with Chinese song. That would be a lot. I know some kids are good and that is.
All right, let's go ahead and get started. Start with public comment. We have one person signed up tonight. Stephanie Almeida. Is that correct?
That is correct.
Okay.
We would
Welcome
like
to the
it.
board.
Wherever you want to stand. You can go
I
up
guess
front
we'll
if you want.
split handouts for myself. So my name is Stephanie Almeida. I'm with Full Circle Recovery Center. We're a local substance abuse treatment program here in Franklin. Last year we were awarded a $100,000 HRSA grant to work on the overdose issue here in Macon County. And we've sort of been all over the place from Buncombe West. My proposal tonight to bring to you is about the legalization of syringe exchange. It was passed last month, and I just want to share my intention of moving forward with starting a syringe exchange fixed location here in Macon County, with the idea of applying for funding for a mobile unit that would work in the entire southwestern region of the state, from Haywood County to Cherokee County. My plan is to work with all the health departments and form a coalition and bring some HIV and Hep C prevention work to the western region. You've got lots of paperwork in there that you can read. Some strengths and limitations of both fixed and mobile locations. The second document is just an article about the legalization. Third document that I shared with you is some information, case study from Scott County, Indiana. I don't know if anybody has seen the CDC report listing the top 5% of the country that's at risk for an HIV and Hep C outbreak, but Clay County is 63rd. Cherokee County and Graham County are both listed. And so, of course, we're contiguous with them and share clients and folks back and forth. There's also a little bit of information about syringe exchange from the North Carolina Harm Reduction Coalition. And then I shared some syringe services, myth versus fact, just some PowerPoint presentation from AMFAR, which is an AIDS prevention organization. I know I don't have a lot of time to speak. We could probably talk 6 or 8 hours about this. But I'm welcome to any questions or immediate concerns.
We have a needle exchange on the agenda for tonight, so we'll be discussing that as a board.
Oh, good.
Does anybody have any direct comments on this Almeida at this time?
So could I have a copy of the agenda so I can see what this might look like?
Are there extra ones back there?
Oh, thank you. Thank you.
You're not too far into it.
Oh, excellent.
Thank you.
You're welcome.
All right, so I ask, call the meeting to order. First, approve agenda. Everybody have a chance to review that? Any changes or amendments? Two changes?
Two changes. One is under old business. B is rabies compendium is going to require a motion by the board, so it should be read on yours. It's not. And also under new old business, we're going to add we can add a section C on the agent vaccination policy. We have some changes in TB and related to a flu vaccine issue. That's the change.
Can I get a motion to approve?
So moved.
Okay.
Second.
Any discussion on it? All in favor? Any opposed? I don't think so. Kathy?
Okay, so once a year, we're monitors have come in and asked us to add to our survey. So the whole month of May, we have these surveys spread throughout the dental clinics, animal services, all the services that we offer here, and offered a $50 gift card as a raffle prize for anyone that submitted a filled out survey had their name put in the raffle. So this year we have a total number of surveys, 79 that were completed. So who responded? Overwhelmingly amount of respondents were English. 89% were English, 11% were Spanish. Compared to last year, for those of you that have copies in your booklet, I put 2015 information at the bottom on some of the slides. Last year we had 84% were English, 16% Spanish. As typical survey response, we have an overwhelming amount of females that respond rather than males that fill the surveys out. Age range. On the left, you'll see 2015, and on the right is 2016. We have a little bit of difference between last year and this year with the respondents. We had a little bit more younger population respond last year, a little bit more older population respond this year. These two slides represent the race and ethnicity, and are pretty interesting to me. You'll see that around 65–66% from 2015, 2016 were white that responded. And in Macon County, the minority population overall is less than 10%. So to me, that's indication that our services, we are reaching the minority populations, and they're coming here and using our services. Because we have over 25% that responded with these surveys. So these were the different services that the respondents were receiving at the time. Some individuals were here for more than one service, like they could have been here for WIC and then got their child immunizations the same day. So you'll see many more services were received than actual respondents of surveys. So we asked about how they heard about our agency and the services that we provide. By friend and word of mouth is the highest and has been the highest number of when people are hearing about our services. And this is a pretty interesting slide. So we asked them how they felt about our agency before they received the services that day, and then after they were finished receiving their services that day. And it improved. We thought that was great to see that their opinion of our agency was that they received the services special. This is not I thought that this may have been a problem, but this is not a problem. They're exactly the same. And not only are they exactly the same from 2015, 2015 to 2016, but last year at the bottom you'll notice that they have the same statistics as well. So for 2 years in a row they've answered those two questions exactly the same. We asked, one of the requirements is the clinic convenient for some of the programs that we provide. And overwhelmingly that, they say it's convenient, as well as how they rate our facility. That has been And they did say that if we would greet and introduce ourselves. And then so we asked, could you describe us in more than 3 words? And these are some of the very, very nice things that were said about our agency. One thing that, and it'll probably keep going, you know, but it's, one thing that we are required to do is build an improvement plan based on our responses from this survey. So if our customers give us some feedback about an area that we need to improve upon, as an agency, we have to actually look at how we're going to improve that and be able to show evidence that we have. So the recommendation for greeting and introducing yourself was something that the leadership looked at and chose that as the focus of our improvement based on this survey. And so we held because of the great results we saw with the survey, we have like a little celebratory get together for about 15 minutes one morning. And at that point, we talked for a few minutes about that was the one area that we received some feedback that maybe we could do a better job. And then also, we were given the instructions to, the section heads were going out to their groups and talking about how they could do a better job with that, and if the staff had any feedback about how we could do a better job with that. And one area that we are going to be seeing a little bit of change is, I know Tammy recommended that we get some plaques for some of the girls up front. If you're working a front desk, many times when you come up to a desk, you don't necessarily have time to say, hi, my name is such and such. How can I help you today? Usually, you know, you're letting them through the door or getting them to the next person. And even if you do have a chance to say what your name is, they forget it real fast. So if they sit down and they're checking in, those girls probably need a plaque that say their name, and so the person makes a little bit more contact with the staff person when they're sitting there and ask questions and so forth. And I think another idea was to have some, like, just some reminders throughout the building. Just remember, when, you know, people don't go into the lobby and say, hey, come on back. You know, have the chance to say, hey, my name's Catherine McGaha. Nice to see you today. Come on back. You know. So we lose, we just forget to do that sometimes. We get real familiar with our customers and we forget that. Not everyone knows who we are. So it's just one area that we're going to try to focus on this year.
Does anybody have any questions for Kathy? I just have one question.
Sure.
On the, I guess it would have been the second slide where it had the gender responses. What percentage of the clients are female versus male?
In reality?
In reality.
I don't know if we know that.
Because you just said males don't respond as often. I'm curious if that's really the case or
It's
not.
just your typical kind of knowledge they fill out surveys as frequently as females. But
I was just being stereotyped, so I was curious.
Yeah, or what is it?
It's
The
very
rest of them have
difficult to
to go
get people up in the middle of these like details and answer surveys.
You look at maternal health and family planning and it's VSEP, Wiseman and so on, those are all programs.
Except, you
Yeah,
know, like the dental
for-
programs that
I think you just asked that just to kind of jab.
She tried to try out a maternal health program.
Thank you, Kathy. All right, on to the minutes from last month. Anybody have a chance to review those?
Only change, it shows me being absent, and I actually made that one.
What's credit for being here, Reese?
All right.
Any other comments, changes?
Motion to approve.
Good second? All in favor?
All right.
Opposed? Okay, old business, needle exchange program. Lynn Lynn, it looks like you're the lucky one.
I am. So if you guys, like I said you guys instead of y'all today. If you'll turn to your 3A in your binder, put in there a section out of House Bill 972, which is where the needle exchange program was approved and signed by the governor July 11th of this year, 2016. A couple things I want to point out here to you guys is that with needle exchange, any government or non-governmental organization, including a local or district health department, or an organization that promotes scientifically proven ways of mitigating health risks associated with drug use and other high-risk behaviors, may establish and operate a needle and hypodermic syringe exchange program. With that being said, either one of those agencies, whether it's a health department or another non-governmental agency, does that. There are listed here in the little B section several requirements. So there's a significant number of requirements that either type of organization would have to meet as far as deliverable goes if they choose to do a needle exchange program. The other thing to take into consideration in supporting a group doing a needle exchange program is that there is state oversight in this, and that is detailed out on the next page under D. So prior to commencing any activities, as far as relationship to creating a needle exchange program, the entity would have to contact the North Carolina Department of Health and Human Services, the Division of Public Health, and actually go through and kind of submit all of their information and what their plan is. And then also, if they're forming a coalition and that's some planning, give them an idea of what's going to happen in that area before they got started.
What we're asking for is the board to approve by a motion for us to partner with Ms. Almeida and support her in her efforts to create a needle exchange program here in Macon County. Who will help facilitate, who will help provide whatever letters of support she needs for grants and other things like that. That would be her program.
Is there a cost with this?
There are some. It's actually interesting. In the bill, they put that no public funds could be used for the purchase of needles or syringes. So that means no state or federal grant monies, no county tax dollars, no public funding can be used. So you've got to go to private foundations and other entities. The state, Nettie, and I can't remember her last name, the Division of Public Health, is working with some folks up there to try and identify some grant sources for health departments, which we would share with Ms. Almeida and give her whatever letter of support she needed to try and get that funding. But you can't use any county money. It's or state money or federal money, which makes it a challenge to do that. There is a program through the state, and I have not asked the question, but I think I mentioned here a couple of meetings ago when we talked about the legislation, that the Division of Public Health, through that Office of Injury Prevention, is going to offer, I think, 600 free syringes and some other items to health departments, which if we were eligible for that, we would share with Ms. Almeida to help her program.
How do you get rid of the used syringes? Is, protocol for that?
Am I allowed to answer?
Yes, ma'am.
Okay, thank you. Yes, there's a protocol.
You have drugs.
Yeah, so there's already a pilot disposal program happening in Haywood County. We already collect syringes here in Macon County. They go to the dump. There's a big sign that tells you where to put them. And so it's already happening here. At the agency level, we would have to figure out what the plan would be for disposal, whether we would share the cost with the county through disposal at the dump, which is what Buncombe County does. There's been needle exchange in North Carolina for a really long time. The Western North Carolina AIDS Project in Asheville has been servicing this area for quite a few years underground. And so there's already a system in place for the process. We would partner with them as well as with the North Carolina Harm Reduction Coalition, which is the statewide agency. And so we'll figure out a plan and be disposing of those appropriately. I'm already collecting syringes, and so if my clients have been coming in active, I always ask them, do you have some syringes? Because I go to ACTO to WinCap, and I'm in Haywood County, and I just get rid of them at the dump in laundry containers, mark them caution sharps, which is legally appropriate, and dispose of them. And I'm finding needles all over the place. I found one 2 days ago in front of Lowe's in the grass. They're everywhere right now.
And an interesting fact about where they put this legislation is they put it under drug paraphernalia in the law enforcement regs, not in the public health regs, under the general statute. That it protects whoever's collecting those syringes, is why they put it there.
So these can go to the dump and they don't have to be on the red biohazard mark?
That's absolutely true. They have to be marked caution sharps, and we request folks put them in laundry detergent containers only because it's a heavier plastic. And, I do have a hazmat container in the office, a small one, in case any of my clients have to use diabetes medication, but that's it. I don't know what the plan will be for disposal. Right now, we're working on just finding some funding to support staffing. The funding restriction is only for needles.
There you go.
And so if there's public funding available, it can support staff, it can support a vehicle for mobile exchange. It just can't provide money towards syringe purchase. And so, like I said, my hope is to partner with all of the 7 Western health departments and figure out how to make this work for the entire region. One county is not going to be able to support the work that we need to do. And my biggest concern is the CDC report that we're in 3 of our counties in the West are in the top 5% of the nation for an outbreak like Scott County. And so that's real scary for me.
This study she's talking about identified 220 counties nationwide, and about 3,500 counties. And 5 of those counties are in western North Carolina. 3 contiguous to us.
So does your grant cover just Macon County at the moment, or does it count, does the $100,000, is that supposed to cover all 7 or 6 western?
So the grant ends at the end of this month. August 31st is the last day of the grant, which culminates with our Night of Hope event that's happening in the community building. So our grant is over in just 2 weeks. We have been every place. My focus has been Macon County, and so resources have always come here first. But I've trained Andrews Police Department, they're carrying the naloxone. We've trained Cherokee Indian Police Department. We're getting ready to train the detention center. I just came from Meridian in Jackson County today. Yesterday I was in Macon County at Meridian, and last week we were in Meridian and Haywood. I will go wherever there's a desire for folks to learn more about what's going on and how to be part of the solution. And so I'm really trying to focus this initiative at all the western counties because there's no funding to support it in one place. It's not going to happen.
And we might be able to assist you with the health departments because we have an 8-county regional coalition that meets every other month that we can probably get you to one of their meetings. The other piece is that to further answer your question about disposal, which I have not talked to Ms. Almeida about yet, but Chris Stahl from the landfill actually talked to me recently, and they do have some concerns, not necessarily because this legislation passed, but concerns about needles and syringes and just the way they're being disposed of at the landfill and potential opportunities, negative opportunities for his employees to sustain the needle stick. So we have had a little bit of conversation that as this progresses forward, we probably ought to involve Chris Stahl in that conversation. As to how they want to handle that there. Because they do, they bury it, and they're running a bulldozer, they run over a plastic laundry container with a bulldozer, and you have a biohazard situation.
Well, I know when we came here 12 years ago, the doctor I bought the practice from, he was going to like Fat Buddies and getting the 5-gallon buckets that they would put barbecue sauce in, which is still not a biohazard, but it's a much thicker than your laundry containers as far as a needle going through.
So storage at the site would probably be a large unit that would be open at the top, and the client themselves would put the syringes inside. Probably comparable to, I don't know, probably not a 50-gallon drum, but, a big container. We would use the biggest container we could. And something that size would probably have to be paid for to be transported. And so that's additional cost. If we dispose of it ourselves and work with the county, or other places have transported it in their vehicle, and like Western North Carolina Youth Project, or like I said, Haywood County, we would have to figure out the plan. So I'm open to anything, honestly. I had a client that was using the same needle for 2 months, and he's using quite a bit of heroin, so he's probably looking at using the same needle 6 to 12 times a day, and his girlfriend is using the same needle. They both have C positive. And so they just don't have any access to resources. And so I'm trying to build a relationship with them to try and get them into treatment, because I'm a treatment provider. And it's just horrible. The situation is just horrible.
Yeah, so the idea would be for Ms. Almeida to proceed on with her venture, and the health department to support her with documentation as necessary, or
Support her however we can, if it's an educational component, or if we have to define that as we go along. I mean, it depends what her need is, but we're willing to support wherever we can.
this would be a venture into a new program for the department, so I think it would be appropriate, if the board feels that they want to partner that way as a department. Motion is appropriate.
Well, I would like to make that motion. I think this is an epidemic that's not going to get better. If there's a solution at all, it's time to start looking for one.
I agree, I'll second. I think it's something we need in the community.
So any other discussion on that? Melissa, you're all quiet down there.
And we spoke before I could have seconded. I'm very much in favor of us supporting this. It's something that they want to be done in this area. I will work on these forms and, compromise if there's any support we can get.
I just have a big issue with the disposal.
Yeah.
That's my main concern. Anything that comes out of my office has to be in real sharp containers. I mean, that's federal. I can't believe that laundry bags and stuff. I mean, that is, and especially for what the contents are. That's my big hang up. It's going to have to be sealed to protect anybody who's transporting products, a person from this agency or
It's actually written into the state law that that's an appropriate container to be marked caution sharp. And so I'm willing to work with whatever the board thinks is safest for everybody, but that means that we do a public education with the community of how they're using needles at home and providing access to those containers for them to the health department. So I'm willing to write whatever grants we can. And
those containers that we're required to use are seal proof or spill proof.
yeah.
Even if some bags marked hazardous sharps, it's the contents that can seep into the soil and everything. This is our landfill, it's our community. You just gotta be careful with disposal.
Yes.
And I think
Whatever the board
involving-
thinks is safest.
Yeah, I think involving person is a big step.
Okay, we have a motion and a second. Any further discussion? All in favor? Any opposed?
Thank you.
Thank you, Ms. Almeida. We appreciate your efforts
Thank you.
and your time this evening.
Yeah, anytime. I welcome all the board members also if you're interested in being part of the planning of this. I'm wide open to you guys participating, and I welcome it. Thank you.
Thank you.
Okay, item B, rabies compendium.
Yeah, I'm going to start off and then Jimmy's going to pick it up. But basically, what we're going to ask for tonight is a motion from the board to move forward on adoption of a rule at the next Board of Health meeting. The motion that we need is for us to be able to publish 10 days before adoption of the rule of any local Board of Health. We have to post that in the Office of the County Clerk within our jurisdiction, and we have to publish it in the newspaper, paper of general circulation within the county. And before we would be able to have you vote on a motion to support a rule, which Jimmy's going to talk about at your next meeting, you would have to do that 10 days prior to the meeting. So we would need a motion, if you're in support of this rule, allowing us to do that.
So real quick before Jimmy goes, or maybe I should ask afterwards, but, so this is a board rule and it's independent of the county commissioners.
Correct.
And it's in the interest of public health.
And it's in the interest of public health, and it applies in this is a little bit different than an ordinance, where an ordinance only applies within the boundaries of the county and not municipalities. Where municipalities have to adopt a county ordinance for it to apply, Board of Health rule applies to all municipalities in the county regardless. So, and we did have that question come up related to the protection of public health, and you're going to answer that in a few minutes, I think.
I was going to let you do it. You could
Comment.
quite better. I
Well,
got my notes from you.
Well,
I
let's
can do it.
hear about it before we.
Yeah.
Let him do that contribution.
Basically, rabies laws, and Dr. Todd, feel free to pipe in anytime. Clarifying on this is, are basically based on the compendium of rabies. And it's published about every 5 years when there's a change. And the latest revision was done in March of this year. It was proposed or was put on the agenda to be adopted at the short session in North Carolina Senate, but it didn't get through, it didn't make the agenda. So what the big changes between the 2011 compendium and this one is mainly to deal with shortening the quarantine period of an animal that's been non-vaccinated or is a little late on vaccine from 6 months to 4 months. And it also, the way the previous law was stated, so let's say you had an animal that was one due past its rabies vaccine, it was automatically considered non-vaccinated. So it was automatically a 6-month quarantine. What the new rule does is basically allows them to get a booster if you provide proof that you've had a rabies vaccine in the past. And if you were not able to provide proof of that, you have the option to submit a blood titer, where they will take a titer to see what the antibody level is, give you the booster, and see if you have that rise in titer. And then from there, it will decrease the quarantine period to 45. Most of that's based out of work that's been done out of Kansas State. The rabies compendium is pretty much considered the national standard on rabies control as far as animals and what the protocols are. So what we're basically looking at is to adopt a standard that kind of goes along with the national standards for compliance. Now, one thing that Jim is kind of alluding to in the past, it's really been kind of at the discretion of the health director, with really a lot of leeway, but not a whole lot of specifics to rely back to. And I think this is better because it gives something to go back and basically this is kind of considered the Bible for rabies control. Dr. Todd, do you have anything you want to add to that?
No, I agree. There definitely are some changes that are, I don't think put the public or the pet owner at risk, but do reward some financial, improvements from quarantine of 6 months. And they've done the study and just found that 6 months. 6 months was really just, they knew it wasn't 6 months, but it was like, well, let's just really be sure. And so that's why the change.
Most animals that will break with rabies will do it within 12 weeks. And, I think this is basically more based on hard science. I think it gives us something more to base our decisions on. Jim?
And the question that Mr. Adams was talking about is that one of the requirements is that a rule by the Board of Health has to further protect the public than the existing general statute. And I had conversations with the county attorney and the attorney Chris Hope at the Division of Public Health, who had assistance in developing the letter that's in your packet, which I think this might be the second page in there. And all three of them said that yes, this does. First, because it gives us a more definitive answer, and I don't have to do so much research into finding an answer for an individual, which then in turn gives me the ability to have a quick turnaround time to respond and get an animal vaccinated and get it into or out of quarantine. So it does further protect the public's health from that aspect. And that's a three-attorney opinion.
And I think the important thing too is that the current North Carolina general statutes are based on the 2011 rabies compendium. They just have not been updated to the current 2016.
And one other interesting fact, and you know, sometimes things become clear in hearings, but we had a long conversation with the county attorney yesterday afternoon. Neither one of the three of us in the room thought about this piece, but there is one fact that is very prevalent, is that based on general statutes, there's only a few things in there. When we have a question, we go to the rabies compendium. So that's our backup document to the general statutes now for what's not covered in the general statute, which we weren't even thinking about, which I mentioned this morning after you thought about it last night. But basically, the model rule that we're going to request is that this model rule for rabies post-exposure management for dogs and cats implements and particularizes the authority given to the local health director in General Statute 130A97, and that's actually in the back of your packet there, along with a copy of the compendium if you want to read that. To effectively and efficiently protect the public's health utilizing the most current science. Accordingly, it'll be the Macon County Board of Health adopts the recommendations and guidelines for rabies post-exposure management for dogs and cats specific to the National Association of State and Public Health Veterinarians in the 2016 edition of the Compendium of Animal Rabies Prevention and Control. And it tells you which part of the compendium. And these provisions of the compendium shall be the required control measures pursuant to General Statute 13897. Now, the other caveat of this is that the Division of Public Health tried to get legislation through to change 138-197 this year, and it just never made it through this process. In a short session, it's hard to introduce something this new and get it all the way through. So there will be legislation introduced in the long session. And now I can't remember when the long session starts, whenever the long session starts, but there will be legislation introduced in the long session to amend the general statute, which at that point, depending on how they amend the general statute, we would come back to you and maybe remove the rule if we need to at that point.
There's a couple other little subtle things in there that I think are important. One of them, it always mentions immediate veterinary care. And that's something that was previously left out of the compendium. So basically what's requiring you is to bring your animal to be examined by a veterinarian and assess the wound and assess the risk and also assess a better health status on the animal. So I think that's an important change, which I think as far as just safeguarding the public health, I think that's an important thing because you're having a professional make that assessment that before was kind of left up to, it could have been like the health director or no offense, or animal control officer, but this way here is requiring a veterinary medical professional to actually do an assessment on the animal. I think that's a very subtle but very important change.
So just to summarize, I guess for me, the 2016 compendium basically makes things a little bit easier on the owner.
And I think it does. It gives the owner more options, and it's based more on hard science.
As well as it financially benefits
The owner.
well, and
The owner
whoever
of the
has to keep the animal for 6 months, 4 months over the 6 months.
And animal services and how to go out to verify home checks and other things. So it saves the county money.
Because I think now we currently have 2 animals that are under 6 months old.
Any thoughts?
Well, it sounds like our board representative, who is a vet, is agreeing
Oh, I
with
was.
it. So I, like Jim, do not have a veterinary professional background either, so I'll go by what the 2 professionals recommend.
Well, I see no reason.
I think it's the standard of care.
That's his name.
It's a national goal.
Well, Dr. Todd, you want to make a motion to,
Yes, I adopt the rule, we adopt the 2016.
I think the motion is, I think the motion we need is to advertise
Oh, okay.
that we're going to adopt it, and then at the next board meeting is when we can actually adopt it.
Yes, sir.
And that would be the motion.
Okay.
Second.
Any further discussion? All in favor?
Thank you.
Does everybody know what the number one cause of spreading rabies in the state of North Carolina is? Raccoons. I think there were 388 positive raccoons last year.
And I'm proud to report we had 2 tested last month, both came back negative.
All right, up next is the agent vaccination policy.
All right, agent vaccination policy. There's 2 primary changes to the agent vaccination policy that we are going to put forth. The first one is around TB testing of new employees. The CDC has made some recommendations around healthcare workers and what they call a 2-step test. And if you have any questions about that, Cheryl Rainey's here somewhere. And she will answer that question.
We need to get caught up. We're missing the handout.
Oh, you're missing the handout.
We're just catching up.
This guy here.
Anybody else need some pudding before I get all this up?
I mean, you can send it to
So the first thing you have in your packet is on the cover of the policy. If you flip to page 3 of the policy, I have highlighted everything that's changing, but the first part is just the references and where we gleaned the information. But basically under section 6.7.5 tuberculosis, the initial part of that is we've always done TB testing on all employees at initial employment. And what we want to do is, based on these recommendations from the CDC, is go back and do a 2-step test on all employees, and then based on the results of that, so we're going to do the 2-step test instead of just the initial regular 1-step skin test, and then based on
Is this for all new employees?
we're going to test all existing employees first. That's the recommendation. And then after that, it would be all new employees. You only have to test employees at the time of employment unless you have a medically indicated reason for testing them beyond that. They've been exposed to somebody. And we have had several TB patients this year coming through the clinic, more than we've had in recent years, which is why we've taken note of this and had a lot of conversation with Dr. Dewhurst, the medical directors, in support of this. And then the second piece of that is employees working in an occupational setting with increased risk of exposure to persons with tuberculosis disease are to receive the 2-step test as close to initial employment as start. So it's not 100% of the employees after we do this first portion. The TB manual, the state TB manual, actually identifies risk categories. So does the CDC. And Dr. Dewhurst reviewed that with Ms. Rainey. And the areas where they've defined would be anybody that works in the clinic, anybody in nursing, anybody working in nutrition, laboratory staff, and then dental services staff, and then any frontline customer service folks in those areas. So it would be the clerks in dental and the clerks here in the building would all be required at the time of employment from this point forward to have that 2-step TB test, the TST.
How is nutrition folks, how are they exposed to TB more?
Based on the population that we see that come through the clinic.
Direct patient care.
Yeah.
And that was my understanding as far as the recommendation was anyone that performs direct patient care.
So like your dietitian.
dietitians, because they do spend, tuberculosis, it takes a lot of the bacteria to actually infect a person. And so when we do TB risk assessments, if we have a suspect, we're gonna look at what are their risks for actually having it. We're gonna do screenings, and, you know, if we're gonna test contacts, we may look at exposure time. So everyone's exposure time is different. If I'm outside with somebody that has TB, they're coughing, that bacteria is gonna go in the air and be swept away. I'm not gonna be at risk, really. If I'm in a closed room with someone for 4 hours, 8 hours, and they're coughing and spitting, that bacteria is gonna sit in the air. I'm gonna be more likely to breathe it in and become ill. So the CDC just defines a healthcare worker, I think, as anyone having direct contact or direct patient care. So to cover our bases, that would be anyone that comes in contact with potential infected people. Does that make sense?
And so what would be the added cost to the department to do all these studies and do these ones twice? Because it's just this initial year, right, that it'll be more expensive.
We have not calculated that out at this point. But we can get that if you need it, if you want to know exactly what it's going to
I was
be.
just wondering.
Yeah.
Is this a $100 test or is it $10?
Oh, no.
20.
Yeah, I was going to say, it's 20, but that includes the administration fee, doesn't it?
That's everything, that's administration and interpretation.
If it's 2013, and that is administration fee, so $7 or $8 per person, an employee. Do you do the two-step test? Yeah. Most hospitals have already been doing this since about 2005. Most inpatient facilities, nursing homes. Cheryl, you want to answer that one? Two-step test?
Can you briefly describe what's a two-step test?
A two-step test, basically, what it is our ability to react to the tuberculin solution as we age or as time progresses, decreases. So in order to confirm that someone's PPD or TB test is a true negative, we do a two-step where you administer the same test at least 2 to 3 weeks apart. It can be as much as 12 months. And it'll cause like a booster phenomenon, just like any other vaccine. So if when a new employee comes in and we place their first test and it's negative, we repeat it again in a couple weeks and it's positive, then what that's going to tell us is that there's potential they were exposed to tuberculosis prior to actually coming and entering our building. They got it somewhere else, not from us. Whereas, you know, if we did serial TST testing in our building, their initial 2 steps negative, 12 months later it's positive, then we may be looking at, okay, maybe they were exposed in our building. Which we do risk assessments in our building every 12 months, which I think Jim has a copy of. We're a low-risk facility, so serial TST testing at this point is not indicated. I know one of the things that Dr. Dewhurst talked about doing was a screening questionnaire versus actually placing the skin test, which is basically just a nurse assessing, does the person have any symptoms, has their risk changed in the last year, should we
Similar to
place
what
one?
we did when we had the shortage.
Right.
Yeah.
That's what we do. After
Cheryl.
we had your initial.
And we didn't include the risk assessment, I'm sorry, it was either 7 or 8 pages long, so I decided not to make.
Yeah, it's a very
I have it if you
lengthy
want to see it.
risk assessment. But, I mean, we've not had, to my knowledge, any active confirmed pulmonary TB cases in several years. We had one that was a transfer in from another county, but her sputum smears were negative. She was not considered infectious to the public. So we've had a couple of suspects, but they were all rolled out. So far we're good.
Thank you.
Any other questions on the TV section? Okay, Jim.
Yeah, the other section is section 6.7. There's one line under 6.7.6.4 that's highlighted. Under the current policy, we it says that we will give preservative-free vaccine or flu mist will be made available for agents upon request. We are changing that, or requesting to change that preservative-free vaccine we made available upon request. And the reasons we're doing that is that the CDC Advisory Committee on Immunization Practice, ACIP, voted on June 22nd, 2016, that the live attenuated influenza virus, also known as nasal spray or flu mist, should not be used during the 2016-17 flu season. The decision is based on data showing poor relative low or low effectiveness of the live attenuated virus vaccine from 2013 to 2016. Basically, the U.S. Influenza Vaccine Effectiveness Network showed the estimate for vaccine effectiveness for the live attenuated influenza virus against flu virus to be less than 3%. Also, in addition to that, the American Academy of Family Physicians has also come out in support of those recommendations. We have notified staff already that after consultation with the medical director here, that because the CDC and ACIP are not recommending flu mist for this season due to the efficacy of the vaccine, that we're saying that flu mist will not be, and they're saying that flu mist will be less than 3% effective for those 2 to 17 years of age, which is the group that they looked at, which just means that for those 18 to 49, it's going to be even that much less effective for them. So after discussion with Dr. Dewhurst, we decided that we will not be offering flu mist to the clients of the health department. Therefore, we won't be offering it to staff of the health department either if it becomes available. Additionally, due to the recommendations and the low efficacy of the vaccine, if a staff member chooses to go outside and receive flu mist, if they can find it, from another source that, based on their medical record's recommendation, we can consider that individual unvaccinated, and they will be required to wear a mask in accordance with the department's vaccination policy.
So basically, we're just taking the flu list out
Taking the flu mist out.
and we put preservative-free.
We're leaving the preservative-free, we're leaving in there. And if next year they come out with a flu list that ACIP and CDC accept, we'll be back to change it back.
Was there somewhere in here that referenced the CDC guidelines annually, or?
Yes, it is. It's right on the first page, under applicable laws, rules, and references, 4.2, the CDC healthcare personnel vaccination recommendations. And we changed that. It had a date, which is the current ones, but we changed it to current recommendations, only because we don't want to change the date every time they change it. But it is.
And that's the attachment.
And that's one of the attachments. That's attachment A. Yeah, that's attachment A.
Well, so if you have current recommendations on that one, why don't you restate it that the preservative-free vaccine for flu mist, if the CDC accepts that as a recommendation, so then we don't have to change this year after year. Because now that the flu mist is out, it'll be out unless we
Put
make
it
that
back in.
effort to put it back in.
We have to review the policy every year anyway, so, and this is the time, so, and based on our county attorney's recommendation, his recommendation was to just take it out. Don't leave it in there, don't leave it. I can take that recommendation back to him, if that's what if the board would like me to do that.
I think somewhere we need to, I'm not sure how it reads. It says current recommendations under that 4.2 section, which would indicate that every year the recommendations would change.
No, it just means that whatever the current CDC recommendation is, we're going to accept.
Okay, so if next year they accept this flu list, we have to remember,
We
we
could
have to
offer that.
remember to have the conversation again.
We could offer that without ever having a conversation again. I mean, if we can purchase it and we can give it, we're going to give it.
It doesn't mean we're taking off the table.
Yeah.
It's just being taken off the table for this year because it's not an option. And then when we get ready to do the flu pre-booking next year, when we look at what the flu pre-booking is and what they're offering, and we'll see what ASIPs and the CDC, then if it's back on there, it'll automatically just trigger us to have to look at the flu policy, because we look at it every year anyway.
I guess I misunderstood, I thought y'all said the reason why you didn't put the year in here, so you wouldn't have to remember to look at it based on the year.
But ASIP only recommends the flu vaccination. It doesn't recommend their policy that references recommends that individuals receive a flu vaccine. It doesn't specify the types of flu vaccine. Where in the policy we specify types of flu vaccine. In my opinion, it would probably be better just to strike that whole sentence and not have that, and offer staff what we have that's available, which we purchase, because, I mean, like last year, we had trivalent vaccine, quadrivalent vaccine, flu mist, we had all of it, but we only named the two, preservative-free and flu mist, because 2 years ago we did that, because of requests by the staff that those be available. And when it came to the board decided that because of the staff request, we put those in there. But that's only two of the many types of flu vaccine that are available. This year we're offering quadrivalent, regular, or quadrivalent with the preservatives, and quadrivalent preservative-free, because those are the two that are available. We're also offering high dose for those over 65. We don't mention all those other ones in here. So it might be even better just to strike that line out and not say that we'd offer anything special, because we offer it. We already do it. I mean, you got flu mist a couple of years ago, as an employee.
Years, I'm not 49.
Oh, no, wasn't you?
I got flu
Oh, no, it was
mist
your daughter. Never mind, I'm sorry. Yeah, you're right. It's
I
somebody
got
else.
flu mist my entire time in the Army.
Yeah.
That's fine.
Yeah.
I loved it.
But, you know, it really doesn't even need to have that line in the policy at all.
Now, this is attachment A, that's kind of messed up.
Yeah, it looks like an H, yeah.
Under influenza there, what is information? It says give,
Internet flu.
Into the nose.
It's in the notes.
That's
Or
the
the
same
nose.
That is a flu mist.
Yeah.
That is a live attenuated virus, but it doesn't specify the type.
But that's still the recommendation from the CDC, is it intramuscularly or intranasal?
Correct, but this year they're recommending no intranasal.
AstraZeneca, the company who makes flu mist, that's who the company who made it. They're not. We've been told by a couple of drug reps that they're not even making it this year because it's not recommended. It's inevitable, so they just don't want us to have
Or
it.
is it on the recommendation?
On the recommendations for there, it's on the CDC recommendation.
That's part of the reason why we're trying to change to the most current recommendation, because those recommendations are made in 2012. They have not updated that sheet, but they've come out with a statement this year saying they are not recommending that we use the flu mist.
Where is that recommendation? I mean, do we have a copy of that?
I can get you the copy of the letter. You have a copy of you have the synopsis from that letter.
Yeah, I was just,
In your
I'm just, we're referencing an attachment here.
On the last page is the synopsis of that.
Oh, and I thought that was the front page. So this one shouldn't even be in, this attachment A, should it even be in there?
Yes.
So, this is off topic, I guess, but, so babies, they're not gonna offer flu mist to babies either?
No children, nobody. 2 years and up is all that could get flu mist before. And they're not offering flu mist to anybody. They're not recommending flu mist for anybody 2 years of age or older.
But we have a vaccine that we can give to 6 months and up.
6 months and up.
So,
Wasn't it the nurse?
no.
It's
Up
always
to
been
nose
2 and
was
up.
2 to 7.
2 to 17, with the exception of 18 to 49.
So we have any other discussion? On the tuberculosis or the flu?
And they still have the option, if they don't want to opt out, let's do the mask thing.
We
That's
still have the option to
other
do that, yes.
How many employees did you have last year that opted out?
Four.
Does that cause problems since there are other people that are in this building that are not health department employees that are not required because they're county employees that they don't have to get the flu vaccination so they don't have to wear a mask?
Correct. I can only establish policy for health department employees.
Right. Does that cause problems within the,
Yes, it does. But at the same time, the staff that you're talking about on this side of the building, not that side of the building, that do commingle with us here, aren't going in and inspecting daycares, aren't going in and inspecting long-term care facilities, aren't going into the hospital to do inspections where the other folks are. They're commingling, they don't commingle with our staff in the rest of the building as the staff that we have that are co-located with them do, commingle with the rest of the staff in this building. I mean, I had a conversation with somebody the other day at the hospital, and you can't even be a vendor or a contractor in the hospital and come in without a flu shot. We got a phone call because one of our staff that they found out, how they found out, I don't know, didn't get the flu shot, wasn't wearing a mask at ladies' night out. They requested that we not send that individual back unless they were wearing a mask. So this is not something that we're doing just to penalize employees. There's good science behind doing this for healthcare workforce, and
When do we have to have this policy submitted back to you by or approved by? I mean, does it have to happen tonight?
well, beginning October, when is it?
It says October 16th.
16th, so yeah, we would definitely have to have something in place in October before somebody's September board meeting.
We usually like to have our staff have their shots before we do the fair,
Yeah.
which
It's just September of the 16th, and we right now don't have the vaccine in yet, so we're still waiting on vaccine. We have some off.
Okay, well, in order to change the policy, we have to have a motion, so.
So we're thinking just to strike the 6764 then?
You can, yeah. It would eliminate that question for next year when they didn't create preservative free with that.
Did you want to offer it anyway to whoever?
If it's available, we're offering it, pretty much.
I think the only thing I wouldn't want to happen is if somebody then did want it preservative free for budgetary reasons or something that then you then have the ability to go back to the policy and say, well, the board voted to take this out of the policy, so we don't have to do it anymore. And I'd hate for us to get some pushback.
We have to have preservative-free on board because the OB program, our pregnant women have to have preservative-free, so that's not something like we typically would not. I mean, we just have to have options available. And we know flu mist is a high demand. I mean, we know that people want it. We've given it at the fair, we've given it different places. So I don't think it wouldn't be an option if it came back, but if it's not an option that's safe for the public and is doing anything for the public, it just seems kind of, to go against what they're telling us doesn't seem prudent either. So, we want to protect the public, not give them something that doesn't really work either.
And just an example, last year we did not purchase flu mist, except for when staff requested flu mist, and you have to buy it in 10 doses. Eight of the doses we had to give to private pay patients because staff only took 2 of the 10 we ordered. So it's not a high demand vaccination for staff anyway.
It's mostly parents like it because of the ease to give it to children, and it's not a shot, so that's more who likes it is the younger age population. I know a couple sites that we've gone to, we've given it because the state would send it to us, but the state's not even sending it to us this year.
And The only reason why it's being brought up is it was brought up by an employee that even though they don't get the flu list, that option was available and they thought staff should be able to get it if it was in the policy, even if it was, the efficacy was only 3%. But based on the medical records recommendation, we're not even going to purchase it, even if it is available, because of the efficacy of the vaccine.
Does anyone have any other discussion? Okay. I guess as of now, it will remain unchanged. All right, new business, the flu plan. That's different.
That's a different thing, I guess. So, this year, we have our flu schedule set, and our first flu clinic will be at the Macon County Fair. It'll be on September the 16th from 1 to 7. It's a Friday. And then we have some other places that we have flu clinics set up at, and we already know how many doses that people have requested. We've started getting some of our flu vaccine in. However, it's been preservative-free and high dose. We haven't gotten any of our quadrivalent in that we typically give out to the public. So once we start getting our flu vaccine in a little bit more, we called, Cheryl called the state today, and the state doesn't even have their vaccine ready to push out yet. So we're just kind of waiting a little bit. We did vaccinate some of our prenatal clients today when they came in. We vaccinated 3 because of the kind of vaccine it was, which there's just a difference. I mean, what you can give private and state, but we just went ahead and vaccinated some people today to get them started. So we have people that are getting vaccines. So we're getting there. We're almost ready, but we're just waiting a little bit. We do have buttons when the staff gets vaccinated. It says, "I got my flu shot. Did you?" to wear through the flu season, to kind of promote people when they come in the building, to remind them to get their flu shot. So we'll be giving those out when we do our staff vaccines. And we just kind of want to encourage people to go ahead and get the flu vaccine this year.
You already started seeing the flu?
I haven't heard anybody starting it. I know that a lot of people are anxious. We have two groups of people. We have the people who want to wait till October because of they think that's when flu season is. But then we have the people who, the minute it hits the places, they really want to go ahead and get their shot. There is no, based on what they tell us now, there is no flu season. It's all the time.
Yeah, I mean, they're still swabbing for the flu.
Right.
So first time of flu of the year today.
You did, so you have seen it. Okay, because I know they're still swabbing.
Yeah. So I just haven't heard it. And school's getting ready to go back next week. And once everybody's been gone and they all get stuck together. Y'all been sick for the next 6 months while everybody adjusts. So. We're ready to roll.
More questions for Jennifer? September 16th, you said?
That's our first one at the fair.
How much do you charge? Is it free at the fair?
No, we have clerks that go with, and I think we did 35 or 25 for the flu, 30 for the flu, and 55 for the high dose.
We just didn't want to do it.
Yeah, that's all we got. And that just means it has 4 strains of the flu in it, 2 A's and 2 B's versus the trivalent, which had the H1N1 and the A and the B.
Did you bill insurance at the fair?
Diane breaks her clerks out. The clerks get them first, we get them second, and then they go on to the fair. Have a funnel cake. It's your justification for junk food.
Right, exactly.
had a monitoring of several of our programs and a new billing and coding guide that came out by the state. So we took the recommendations from the monitoring and compared it with the billing and coding guide that came out and updated our billing and collection policy to meet those requirements. I have gone in and highlighted the changes, additions, and clarifications throughout the policy. Most of it pertains to child health, family planning, and maternal health. We clarified the sliding fee scale that we use, so there's not any misunderstanding that we're not using the recommended 250% of poverty scale. So you'll see the wording will follow throughout those programs that use that same sliding fee. Again, that's child health, family planning, and maternal health. I think family planning had the most additions to that because we needed to make sure that we included the confidential services statement in that, even though it was understood, it wasn't clearly defined in the policy. And the fact that we can now not charge anybody more than what the percent pay is. So if their insurance charged a co-pay, we would need to evaluate that against whatever their sliding fee percentage is and choose the smaller amount that they would owe after the insurance paid. And with that, you say that a confidential, the family planning, that includes minors. it does. Anybody that presents for family planning services, and they walk in the door and say, I request confidential services, we have to make accommodations. But they have to know to say that. We generally ask if it's like a 14, 15-year-old that comes in, does your parents know that you're here? So that determines how we figure their sliding fee as well. Okay.
So both these changes are becoming in compliance with current guidelines.
That's correct.
Does anybody have any questions on the changes?
Under, on page 5, out-of-county service restrictions, I have read through this thing completely. The mandated, how long is that list that's mandated by federal law? Diane, is that a?
Which program are you?
Oh, I'm sorry, out-of-county service restrictions on page 5.
Okay. Well, there are some programs such as family planning and STD that we can't have any borders around because those are federally funded programs. So that.
Unfortunately, any federally funded program, we have to take all comers regardless of whether they're Macon County residents or not.
And that's the health center services. All of those services and federal law.
We just didn't have the federal law in that paragraph. We had everything else beforehand. That's the only thing that we added to that paragraph.
I had brought to attention at one of our board meetings that in the adult dental, is that in here? That it was that someone had said that the commissioner did not want them servicing out-of-county patients, and we, the commissioners, never did. They don't know what, commissioners don't know what goes on in these programs, but we don't take out-of-county in adult dental or in
Adult or
dental?
child dental, we don't take out-of-county residents, no.
Why do we not do that? If they got cash or?
There's enough of a need in Macon County that rather than change the rule to seeing patients from out of county, that if we adjusted the sliding fee scale, we'd probably have more patients. We've heard the same complaint out of dental. We've reviewed their appointment schedules. We've had face-to-face time with them. There's not as many open slots as one might think or be led to believe there are in their schedule. But the objective of the program is to serve Macon County residents. That's why it was started. And if we're looking at that, why would we look to service or serve people from out of county who might have money when we could be servicing or changing or adjusting our sliding fee scale to see patients who live in Macon County who may not be able to afford to come to our adult dental clinic because we're a slide.
Yeah, I understand that's the primary thing, but if they have those boys, I don't think they're busy I don't think they're totally maxed out, are they?
Some days when Jimmy and I both look at their schedules. You want to answer?
Year round?
Yes.
Seasonal.
It's year-round.
Year-round.
Now, the thing that they don't have control over is no-shows.
No-shows.
And some days you'll look, they'll have 2, 3 no-shows, some days they'll have none. But if you look 2 to 3 weeks out, they're both,
And there's a way to solve no-show rates, but
they resist.
they're resistant to that suggestion. Of course.
What is it?
You build a back schedule and you just schedule an extra patient in the morning for the hygienist and the dentist. Some days you might be behind, some days you might see everybody and get behind. And some days you still might have that no-show and you'll finish the day with a full load for that day. It's very easy to do, but we've met a lot of resistance at adult dental for doing that. A lot of resistance.
So that's basically overscheduling yourself.
You basically overschedule yourself by one patient a day. And their average is about, on the days they have no-shows, is about 2 no-shows. On the days they have no-shows, and that's not 5 days a week.
They average, when we were part of that Blue Cross Blue Shield, they were averaging about 15 to about 16% no-show rate, which in actually comparison to most public health adult dentals, it's a pretty good rate.
That's a really good rate.
Now, of course, child dental is like 3% because they don't have an issue with when the child's not there, they just go get the next one out of their seat. But their no-show rates are historically not bad, but then you'll have a rash where, it's a long weekend and you'll have 3 or 4 people no-show. And it's kind of, they can even call them and confirm them at 8 o'clock for a 10 o'clock appointment and they say, yeah, they're coming and they get them. It's hit or miss.
Yeah, if the guy walks in and had money and they're sitting there, wouldn't it be appropriate to take the money? And leave it just as kind of instead of having a strict policy.
The problem is,
can.
once you establish care, you establish care. And I can tell you our dental and medical malpractice insurance carrier would tell you not to do that. You can't open the dental urgent care.
When you break it, you buy it. Once you start, you're committed.
You're committed
And that's it.
to that care plan for that individual.
It's hard to do just palliative treatment, especially if somebody has just a massive amount of work done or work to be done. Once you start that case, you kind of should see it through.
I think the thought being there, Paul, is that once you establish the patient, you have the patient for 2-3 months, and then now all of a sudden they can't pay anymore, and they're out of county, you still have to take care of them for a period of time or until the care is completed.
So they leave your practice or you disenroll them. You can't just disenroll a patient because you want to disenroll a patient. You have to have a valid reason or anything to sue.
And still, if you do dismiss a patient, legally you have to provide emergency services for 30 days.
30 days.
Afterwards.
Surprised their no-show rate is that low, just because, when you think about a lot of those low-income people, they're getting public transportation, you have to secure that within 24 hours, or you think you get a ride or you don't get a ride, or your cell phone changes all the time so you don't get the follow-up call. Heck, I miss my dental appointments half the time when I don't get a call.
probably like me, forget it.
Yeah, because it's 6 months out, and so I don't think about it. So that's really, I'm surprised that it's that.
I mean, I was surprised. Because actually, when we went into it, I thought our commercial rate was fine. And we started talking to everybody else. And a lot of other clinics, they were running 30, 40% no-show rates. So,
So any other thoughts on the billing guide? In order to change it, we need a motion to change it as highlighted.
You want to go ahead and make it a package deal with the fee?
I think that would be
Right,
similar.
that'd be separate, yeah. That'd be two separate.
I make a motion to accept the changes made.
Second.
Any further discussion on it? All in favor? Anyone opposed? Okay, fee plan.
We included the entire fee plan this time. Over the past several months, we've just given you guys highlights of things that were changing, so we wanted you to be aware of all of the services that we offer right now that have a fee. Now, these are clinical services, and then you'll see animal services and environmental health. So you've got all of our fee plans down there. We would ask, as you're looking through that, in the last column of the clinical fee plan, we've got some changes that we are requesting. Again, some of this is new guidance from the state. You'll notice that the list of J codes on that first page are all meds, such as our family plan and depot injections, the IUDs, the new next one on. The new guidance from the state is that we cannot charge more than what we pay for the drug. So fortunately, we are able to get those at a price through the 340B program, which is administered through the Health Resources Service Administration, HRSA. So this will reflect the prices that we have to pay for that. And it's kind of, we took like an average of the last three to build in a little bit of a cushion so we wouldn't have to come to you every single month when we have to reorder. Because you know how drug prices are, they seem to rise every time. So we're only looking at maybe $2 or $3 above what we paid for it the last time. We did include the Lalito, which is a new IUD. We may or may not use that, but we wanted to have it available in case we do. And that's also would be purchased through 340B prices. On the second page, we've added the EKG services. Now that we have a new EKG machine and Dr. Dewhurst is able to provide that service, we need to have a current fee for those. And then there's a couple of lab tests that are included.
So the fees are either new fees or they've been reduced.
Yeah.
So that requires a vote.
When we get through all the fees,
Oh.
vote for all fees.
So I would make a motion for reduced cost.
Okay, so on there was no changes in animal services?
No changes, animal services, but they've not approved animal services fees.
no, I don't think so.
This is the first time they've included in our fee plan, as part of our fee plan.
Basically, a microchipping.
And that one,
That's a new
approved.
service.
Yeah, that's a new service that was approved by the board here, then the board of commissioners.
Actually, before we took over, they probably had double or triple the fees, amount of fees, and services that we no longer provide. But we kind of consolidated them down. That's pretty much what we charge them. I know our adoption fees are in line with the Humane Society. we can have an adoption special 45, and the reclaim fee, and the citation fees for when the officers go out and issue fines. And then pet carrier, that's just something, it's just a cardboard box that no one seems to have, and they adopt a cat. And then the quarantine fee is basically if I notify you that, I have your animal and you tell me you're gonna come get it, and you wait 4 days to come get it, then you get charged an extra day of order fee. It's pretty streamlined.
Jimmy, what is that, based on the animal officer control discretion?
Basically, normally what we do is the first time, we usually give them one, normally. And then the second time is, if it's a repeat offense, and normally it's a $25 fine.
That's when the animal control officer goes to the house
Yeah.
for whatever reason?
Yeah, and then usually, and then if it's a repeat offense, then it's 50, and that's written into the county ordinance. But normally we try to, if it's nothing too dramatic, we try to, see if we can handle it with a verbal warning. And most of the time, that's all it does. That's what it's supposed to do.
Is that difficult to be enforced?
How does that money come?
Yeah.
They come by and they have to pay it, and then it gets entered into the system and deposited into the health department. It's recorded under news. They have to come in and physically pay it. They can't pay it on the spot. They have to come in the office.
Prior to us taking over animal control, they would issue citations and they weren't being enforced. And we've taken a different tact. And we are asking a question because, we can file a civil suit against somebody or eventually criminal charges against somebody depending on what they've done and what the citations are issued for if they have corrected behavior. But we also are having a conversation with the county attorney about whether we can do the same thing for these folks we do for folks that use other health department services, which is that we can send them to collections, or we can use debt setup and take it out of their state income tax money. Get it first before they get it. But we're still exploring that option.
Does that answer your question? Because if they have a citation book, and when they come back, it's in true because they give one copy to the citizen, and they take one back in its file. So the citizen comes in and they pay their fine, they're given a receipt, and then it's marked as paid. And then we're starting to track a little better the outstanding ones, and we're tracking.
And when do they go out and visit? Like when somebody calls and complains about it?
That's normally it.
If they're out of the,
That or a dog fight or.
It's usually, it's a citizen complaint, about a stray animal or the neighbor's dog being disruptive, or chickens. We've had more chicken calls that are kind of funny this week, but that's normally what it is. But we normally don't try to find people. We're not there to make a killing. We're there to try to correct the problem. But you got some people that just basically dumb their nose at you. And then, if you don't enforce it, then you kind of lose your teeth on trying to control it.
So once a citation is administered, at what point does it become outstanding?
Well, it's 30 days.
And then whose job is it to enforce it?
Animal controls.
So they just go back out again?
They go back and they issue another one, if it becomes repeat, they can turn it over to the magistrate.
But we're trying to create another
Route.
possible option before going to the magistrate court, so that we can collect the penalty. Because sometimes the behavior if they correct the behavior, but they just don't pay the penalty, they don't pay the citation.
Right.
Thanks, Jim.
No problem.
Kyle, is there any changes? Any other questions on the fee schedule? Not need a motion to approve as presented.
so moved.
Any other discussion on it? All in favor? Anyone opposed? Okay. fair handout.
This fair handout, section 5, A.
Okay.
That just lists the times and dates of when we're going to be there. For the fair.
And are you doing like the flu shots every day, or are you just doing this one day? So you know?
One day on Friday, the 16th, and we're doing them from 1 to 7.
Are you advertising that?
You're already called.
Annual update list of committees.
If you are a member of a committee or a board, if you will let me know, write it on that paper and turn it into me so I can be committee member for you.
That's under tab
5B.
budget update.
See.
And this is first week, which is the first month of
This is the
how we ended up.
second month of the first, that you won't get till September. Just the county, but they'll close out their year. When county closes out their year, we do it like 15 or 16, from 17 now, which applies.
Do you have anything you want to add for next month?
Before we go off that, the committee list, any committees that you're on, please put on there whether you think they might be related to public health or not, because it may be that you're in Kiwanis. We want to know that. It helps us when we have to go and do some, we need to do presentations or other things to have contact.
And accreditation for that too.
You know the importance of it? If in the next 4 weeks, if anybody has anything they want to add or maybe talk about next month, then just get with me and see about it. That's fair enough. All right, next meeting is September 27th, 6 o'clock, 6:15, I guess, right?
Motion to adjourn.